So you and I didn't get the pink memo, but you got the
Well,
pink
why don't we go ahead and get started? Thank you very much for joining us in this session titled Managing Worsening Heart Failure with Reduced Ejection Fraction Strategy for Successful Outcomes. I'm Javed Butler from Dallas, Texas, and I'm joined by three of my colleagues who conduct this session today, Dr. Steve Green from Duke, Dr. Nancy Albert from Cleveland Clinic, and Dr. Robert Page from Colorado. We have a couple of presentations and a panel discussions and then question and answer session. So we will try to keep the lecture part of it relatively short, say about half the time for the hour, and then keep half hour for full practical management related topics overall. A few quick comments before we go ahead and get started. First, I would like to thank Merck for providing the educational grant for this program, and I would like to thank Vox Media for sponsoring this symposium. To receive credits, please complete the evaluation form that is on your seats and return it to the staff at the end of the meeting. Please see faculty disclosure information in the handout. Representative slides are included with your handout. Presentation may be viewed later on CMEPlanet.com. Question cards are included in your handouts. So there will be personnel walking around that will collect the cards, so please ask us as many questions as you want to, and we'll try to answer all of them. Let's try to make it as practically relevant, this program, as possible. To be made aware of the future programming, follow @CMEPlanet on Twitter and other social media. And please, if you can turn off your devices to silent mode, as I should do as well. So with those few introductory comments, let's start with the first presentation, Worsening Heart Failure in Patients with HFrEF, examining the impact, contextualizing the risk, and facing the challenges of optimizing GDMT. That's a long title, Dr. Green. By the way, Dr. Green, we were supposed to wear pink shirts and dark pants, but Dr. Page never follows rules.
I didn't get the memo, Dr. Butler. But I am wearing pink pants. So there you go.
For the record, the pink shirt and dark pants is the official outfit of Worsening Heart Failure. So, in any case. Well, very honored to be here today and look forward to a great session. But to kind of kick things off, let's put heart failure risk in its actual true context. Now, throughout all these different fields of medicine, you hear the phrase high risk, and pretty much every disease state seems to have its own high-risk variant. But really, it's important to realize that not all high-risk conditions are created equal. It's important to anchor that relative, that subjective term high risk with the actual absolute risks of bad things happening. And just for context, conveniently within cardiology, we have the cholesterol guidelines, which for some time have been using the pooled cohorts equation to estimate, risk of heart attack or stroke. And they also use terminology in those guidelines. So for context, they're talking about patients with high risk. That's be someone about a 2 to 5% annual risk of heart attack or stroke. There's even a very high risk term they use, and that equates, when you look at the real world evidence, to about a 5 to 8% per year risk of heart attack or stroke. And while I certainly wouldn't want it to be my own risk of heart attack or stroke, I agree, 5 to 8% per year seems like very high risk. But if that's very high risk, what on earth are we going to call our patients with heart failure? Even our most quote-unquote stable outpatient who has no complaints, NYHA class 2, never been hospitalized. They're talking about a 1-year risk of CV death or heart failure hospitalization of 10% per year. We can't get risk lower than that in heart failure. And then our patients that have worsening heart failure, the topic of our conversation today, they have exponentially higher risk. They're talking about 40% in some studies risk of CV death or heart failure hospitalization over a coming 1 year. So again, if we're going to use terms like high risk for all these other conditions, heart failure is truly an extreme high risk or very extreme high risk condition. But also just to level set what we're talking about today, we're not just talking about hospitalizations. Key concept is to understand that worsening heart failure can happen outside the hospital. So there are multiple data out there now, but trials like MADE at CRT, Paradigm, DAP-HF, they've all done secondary analyses with what were the outcomes after worsening heart failure with an outpatient visit, worsening heart failure with a hospitalization. And the bottom line is, irrespective of the location of care, worsening heart failure carries an extremely poor prognosis. You look at the rates of mortality here, doesn't matter where your location of care is, very poor prognosis. Hospitalization for heart failure, I think of it as a care strategy, one of potential many different care strategies we can think of taking care of these patients with worsening heart failure, but it does not define worsening heart failure in and of itself. But then again, what is worsening heart failure then? I just told you it can be things outside the hospital, but what is it? So I think there's really 4 key ingredients to the worsening heart failure definition. 1, deterioration of heart failure signs and symptoms. 2 is this needs to be happening in a patient with established chronic heart failure. So we're not talking about de novo, new onset heart failure. That's a separate bucket. 3 is that worsening needs to be happening despite some level of stable background therapy. So the person can't be completely untreated, for example. They need to be on some stable background therapy. And then 4, the current definition does require a change in treatment, some urgent escalation of therapy, whether that's putting the patient in the hospital for IV diuretics, outpatient IV diuretics, or even thinking about outpatient oral diuretic escalation. So those really the key 4 ingredients to be thinking about the worsening heart failure definition. Again, irrespective of location of care. Well, we just talked about what worsening heart failure is, but how common is it? And I think we all know the answer to this question. It's extremely common. To kind of put this in context, Dr. Butler published a great paper a few years ago in JACC that showed that among patients newly diagnosed with heart failure, you just follow them for 18 months after they're diagnosed, about 1 in 6 are going to develop worsening heart failure. And again, just over the next 18 months after diagnosis. And then when you look at, well, how common is it among all the patients that come to the hospital, which is really driving up a lot of our healthcare costs, of course, and all the poor outcomes, it makes up approximately 80% of all heart failure hospitalizations really are for this worsening heart failure phenotype. So really it is everywhere we look in the heart failure space, there seems to be worsening heart failure. So that's some of the different nomenclature and kind of level setting background information. Now let's talk about the challenges and how we're going to overcome these challenges with optimizing our GDMT. So we just talked about how heart failure and worsening heart failure are very extreme high-risk conditions. Yet paradoxical to that, our status quo approach has been one where we are taking our time with initiation of therapy. We do one move at a time, serial, selective. That's the status quo approach. You might have a patient newly diagnosed with heart failure. People maybe start them on only 1 or 2 drugs. Then you up-titrate over the coming days to weeks and months. Then you start a 3rd drug, wait a few more weeks or months, then you start a 4th drug, and you celebrate finally got them on quadruple therapy. But if you just do the math for what this status quo approach is really doing, it can take 28 to 56 weeks before GDMT is fully implemented at the maximally tolerated or target doses. And at each step in this long circuitous pathway, you have multiple things get in your way of success potentially. You have missed clinic visits, you have hospitalizations, you have maybe clinical inertia where you're rushed in clinic and you're like, oh God, we'll just think about it next time, consider it in next visit in 3 months. The bottom line is while the patient is on this long circuitous pathway, they are needlessly exposed to excess clinical risk of death and worsening status. And the status quo approach, well, what does it buy us? Well, it buys us enormous gaps in GDMT, and we've seen this time in, time out. These are data from the CMEPlanet trial, or a registry from a few years ago now, but it just shows that patients come in clinic visit after clinic visit, we shake hands, pat them on the back, and say, we'll consider making changes next time. There's overwhelming culture of clinical inertia. I have the picture here. That's someone falling asleep at the wheel. That's our average approach to our outpatient heart failure care, in my opinion. And patients are coming in with blood pressures 120 on average, EGFRs more than 60 on average. So again, strongly suggesting there is room if we're paying attention to initiate and escalate GDMT, but again, the falling asleep at the wheel approach dominates. And even when patients are hospitalized for worsening heart failure, again, it should be a sentinel event, alarm bells going off, yet there's minimal initiation and titration of GDMT during these worsening heart failure events. These are data from the Victoria Registry. US and Canadian patients shows that, again, we don't make many changes. And it all culminates at time of discharge when the patients are going home with blood pressures 110 to 120. Again, EGFRs 50 to 60 on average, strongly suggesting that if we're paying attention, there would be room to escalate GDMT, but we have 1 in 3 going home on no dose of an ACE/ARB/ARNI, 1 in 4 going home on no dose of a beta blocker, and more than half going home on no dose of MRA. And when you don't initiate GDMT, when you delay, not only are you exposing that patient to excess clinical risk, but you're also, the unfortunate reality is, essentially having this be never initiation or at best substantial delay. That's the consequence of kicking the can down the road and not initiating GDMT. These are data from Get With the Guidelines Heart Failure, which shows what happens when you have an eligible patient at time of discharge, and you choose to either initiate or defer. You see that if you defer therapy, for example, of ARNI and MRA, you have more than a 75% chance that patient will not receive therapy over the entire 1-year follow-up. So what you do in the moment can stick with the patient over the long term. It's very important. So how do we overcome this, what I would call an overwhelming culture of clinical inertia for heart failure care? Well, myself and colleagues, including Dr. Butler, back in 2021, we proposed the concept of simultaneous or rapid sequence initiation of quad therapy. And the key concept here is to start all 4 mortality-reducing drugs without delay on day 1 or in rapid sequence within a maximum of 1 week. And importantly, this would focus on initially low doses of ARNI, beta blocker, MRA. There's only 1 dose of SGLT2 inhibitor. But after you at least sprinkle low doses of all 4, then we focus on up-titration over the coming days to weeks. And then the following year, the guidelines came out in the United States. And the front and center was, of course, the 4 pillars now, SGLT2 inhibitors, the newest class 1 therapy for HFrEF. But not only did these guidelines say what we should be doing, they also, importantly, if you read them, commented on the tempo with which we should be doing it. And they actually note that these therapies can be started simultaneously without getting distracted over what specific medication sequence to follow. But importantly, do not delay. They should not be delayed. And you know, in the audience right now, you're probably thinking, okay, well, sounds okay, Steve. Let's start the therapies quickly, yada, yada, yada. But important to understand the data supporting this. Yes, it's in the guidelines, but there's also data. And it comes with understanding, first and foremost, that for all these pillars, it doesn't take months or years on therapies for clinical benefits to show up, but just within days to weeks of starting the drugs, you see very early separation of event curves for hard clinical events, such that you can easily understand that delayed initiation of any of these 4 drugs in an eligible patient, even a couple weeks, equates to needless exposure to excess clinical risk. And then when you also understand that the benefits of all 4 of these drugs are fully additive, and you remember we're talking about that extreme high-risk patient population, they need all the help they can get. We should leverage the fully additive properties of these GDMTs. But of course, anytime you're talking about rocking the boat with the status quo, there's going to be hesitation, right? And what the common question I always get is, well, Steve, you know, won't starting multiple medicines at once increase the risk of medication intolerance? And the thing I'll say first and foremost is there's no objective evidence that simultaneous or rapid sequence initiation increases the risk of medication intolerance. And there's actually no evidence that delaying accomplishes anything beneficial. But I will say a couple key comments for context. The one is tolerability is enhanced by focusing initially on the low doses. So we're talking about like carvedilol, 3.125, spironolactone, 12.5, okay? Don't forget, we're not talking about starting target doses all at once right away. Point number 2 is that SGLT2 inhibitors are MRA, so 2 of the 4 pillar therapies rarely cause symptomatic side effects in and of themselves. And then point number 3 is perhaps the most important, but that's to understand that HFrEF disease progression may be misinterpreted as medication-related adverse event, and that this disease state worsening is much more likely if we delay initiation of any of these 4 drugs. Okay, so you're thinking, well, what is he talking about? What does that actually mean? Well, to illustrate, let's look at the panel on the right-hand side. This is from Emperor Reduced, just to illustrate the concept. Your odds of a patient getting better NYHA class or getting worsening NYHA class go in completely different directions based on whether you initiate an SGLT2 inhibitor versus essentially defer, give them placebo. So put this in a clinical context. Patient comes to your office today, they have no complaints. You're like, oh yeah, I'm not going to rock the boat. I'll just, talk about maybe starting an SGLT2 inhibitor in a few months or something. Well, by doing that, you are essentially indirectly increasing the chance that 4 weeks from now, they come back with worsening NYHA class. And then when they come back with that fatigue or shortness of breath, then you're on the slippery slope of saying, well, maybe it's because of the beta blocker they're already on. Maybe I need to de-escalate the beta blocker or other GDMTs. When in fact, this entire situation could have been potentially prevented. If you had a time machine, you can go back 4 weeks and say, hey, I'm going to start a therapy that prevents the worsening of NYHA class, prevents me getting in that sticky situation with trying to disentangle heart failure from GDMT side effect. But even still, people will say, okay, Steve, sounds great in theory, but how do we actually know this works in a randomized trial of starting all the drugs at once? You haven't had that trial yet. Well, we hadn't until 2022 when the Strong HF trial came out. And for those who aren't familiar, this was a multinational trial. Patients hospitalized for heart failure, and prior to discharge, they were randomized to either rapid sequence simultaneous in-hospital initiation of GDMT versus usual care, the serial, slow, status quo approach. They were followed post-discharge for up titration in aggressive fashion, and the primary endpoint was 180-day heart failure readmission or all-cause mortality. The trial was stopped early by the DSMB because it was deemed no longer ethical to keep randomizing patients to usual care. That's how strong the results were of the Strong HF trial. And this just kind of summarizes the slide here. And what did that rapid sequence simultaneous GDMT approach buy us? Well, it bought us overwhelming positive clinical trial across all the different domains of endpoints. For the primary endpoint, 34% relative risk reduction for heart failure readmission or all-cause death. That equated to an enormous absolute risk reduction, 8.1%. Number needed to treat to prevent a death or heart failure hospitalization over only 6 months, only 12. But it wasn't just about the clinical outcomes. Patients also felt better. They had also improvements in their congestion scores and incremental lowering of NT-proBNP. And for those that were so worried about the safety and tolerability of starting multiple medications at the same time, rapid sequence simultaneously, no significant difference in serious adverse events compared with usual care. So to sum it all up, worsening heart failure is common, and it truly is an extreme risk condition. It's got a prognosis comparable to cancer. Patients face substantial risk of subsequent disease progression and death. And despite this risk of cancer, we have enormous gaps in our GDMT. The status quo approach of this one move at a time, slow, serial selective, it results in needless and prolonged delays in GDMT optimization. And the unfortunate news about that is it leads to excess heart failure hospitalizations and deaths that could have been prevented if we did early, upfront, comprehensive, aggressive GDMT. And then lastly, rapid sequence simultaneous initiation of quad therapy is the foundational strategy for improving outcomes for worsening HFrEF. We need to start all without significant delay or prior to hospital discharge. And the top priority, again, is initiating at least low doses of all 4 of the medications. So with that, thanks very much for your attention.
Thanks, Steve. So let me just move on and talk a little bit about some management aspects of patients with worsening heart failure. If I can have my slides. Excellent. These are my disclosures. So the first question is sort of why worry about worsening heart failure, right? I mean, there's enough classification out there about HFrEF and mildly reduced and preserved and improved, and sort of why are we creating this new category of worsening heart failure? And the reason is that if you sort of look at the journey of patients with heart failure, you kind of have risk factors, you develop heart failure, you're really at a high risk, then we give all sort of, our foundational therapies, the risk comes down, which is the middle, which is the yellow part of it. But remember, there's substantial residual risk still there on foundational therapy that we need novel therapies. But the person gets kind of, they don't come into the hospital, they don't come for unscheduled clinic visits. Whatever their symptoms are, they kind of just, adapt to that and they're sort of cruising along. Maybe for days, weeks, months, years, all the patients have sort of a different trajectory. But there comes a time where either in the absence of anything else going on or something which is sort of relatively trivial, right? My grandchild came and had a runny nose, and then I had a runny nose, and now, I have 2+ edema, or I missed my medicines for a day, like relatively very trivial reasons for which other patients do fine. I mean, these things happen in life. But they start sort of getting more tired and more short of breath and a little bit more edema, and they're just not the same, and that you're thinking about that this person needs some more therapy. I need to go up on the dose of diuretic. I need to add a second diuretic. That is what we're defining worsening heart failure. And the reason for that is that once worsening heart failure kind of progresses and you get hospitalized, we very well know that one hospitalization is a risk factor for second hospitalization, third hospitalization, and then obviously not only a higher risk for mortality, but you sort of go through this cycle where you come to a point where you pretty much become refractory to medical therapy. And at that point, if you're a viable candidate, you're talking about transplant and VAD, and if you're not a viable candidate, you're talking about palliative care. And what you're trying to do is to stop that progression to that point where a person becomes resistant to medical therapy because they have become so far advanced. So that's the reason why it is so important of identifying worsening heart failure and jumping on this patient population. Now, there is a little bit of a sort of a chatter out there, and in the Q&A session, if somebody has any questions for HFpEF, happy to answer that, but this presentation is limited to HFrEF. There's a little bit of a thing that, we have too many medical therapies, right? We have RNE and beta blocker and MRA and SGLT2 inhibitors, and that, do we really need another therapy? And the question is, how do you answer this question, whether we have too many therapies or not? So the answer simply cannot be numeric, right? You cannot say, well, 2 are too few and 4 are too many, so 3 is the right number of medicine, right? So the question is, what is the residual risk? What is the need for therapy? DAPA-HF, which is shown here, is the lowest risk trial we have done in the heart failure space in the last decade. Lowest risk. These were the patients, 70+% were NYHA class 2, 100% of them were in the outpatient setting. GFR less than 30 were excluded, advanced comorbidities excluded. They were in a clinical trial setting, which is artificial with much closer follow-up. And they were getting baseline medical therapy, which was more than any other registry has ever shown. Phenomenal medical therapy. 90+% on RAS inhibitor, 90+% on beta blocker, 70+% on MRA, and 100% on SGLT2 inhibitor in the SGLT2 inhibitor arm. These patients should practically be immortal. Look at the area under the curve, right? So we are all very happy at the glass half full, which is the separation of the curve, and a great success. But look at the area under the curve. The annualized event rate in these patients was 11.6%. More than 1 in 10 patients died or got re-hospitalized within a year. Now, you take this group of patients and you modify the risk a little bit, and I'll show you some data like worsening heart failure. That risk goes up to more than 35%. So I just want to emphasize what Dr. Green was saying, that these are our lowest risk patients are still very high risk patients. So that's one reason why we need additional therapies, even if they are able to tolerate all the medications. The other reason is that for a whole bunch of reasons, blood pressure, creatinine, potassium, congestion, heart rate, dizziness, whatever the reasons are, there's a lot of patients who are unable to tolerate the therapies. And in fact, the more sicker you get, the less you're able to tolerate. That's the irony, that the sickest patient needing the most therapy are the least likely to tolerate the therapy because of their blood pressure and creatinine and GFR, etc. And we know that even when therapy is with good faith started, so one issue is inertia, the therapy is not being started, but even when the therapy is started, a good quarter of the patient or a third of the patient, we have to stop the therapy because of intolerances as well. So traditionally, we have really focused on neurohormonal medications, ACE inhibitor, beta blocker, RNE, MRAs. We've sort of hit a ceiling. Some of the neurohormonal modulators and HFrEF since then did not work out, like vasopressin antagonist and endothelin blockers. So we need to look at sort of other targets other than neurohormonal activation. So SGLT2 inhibitors are in that category, and the other drug that I want to talk about is Vericiguat. So what is the mechanism of action of Vericiguat? It's incredibly simple. Sometimes we tend to make things a little bit more complicated. For normal functioning of our multiple organ systems, so we are going to focus primarily on the cardiovascular system, but renal, brain, multiple system, you need a functional nitric oxide system. So what happens is your nitric oxide comes, it binds to soluble guanylate cyclase. The combination of the two, it starts producing something called cGMP. cGMP is an important cofactor that is involved in a whole bunch of different enzymatic function across the cardiovascular system. Now, when you have nitric oxide deficiency, then your cGMP doesn't get produced because your soluble guanylate cyclase is not activated, right? So in chronic diseases like heart failure, where there is a high oxidative stress, the nitric oxide is shunted to the oxidative stress pathway. So what do you do? So this drug, Vericiguat, what it does is it binds to the soluble guanylate cyclase, and it does two things. A less important mechanism is that it increases the sensitivity of the soluble guanylate cyclase to the nitric oxide that is available. So in the past, there was this much nitric oxide, now there is only this much. Okay, fine, it'll try to attract even this much. That's not that important. The bigger thing is that it directly, by combining Vericiguat, by combining the soluble guanylate cyclase, it starts catalyzing the production of cGMP. It normalizes or near normalizes the production of cGMP. And the promise is that that will lead to normal cardiovascular functioning, which is dependent on cGMP. So that's the mechanism of action of this drug. Now, all of these heart failure therapies, beta blocker, ACE inhibitor, MRAs, all of these, when you start a development program, you kind of make the choice, whether you first go in the less sick patient or the more sick patient. With Vericiguat, we went to the more sick patient because there is more need for these patients. But there's nothing fundamental about the biology of the molecule or the mechanism of action that it will only work in worsening heart failure. That's a strategic decision that let's go first in the more sick patient population and see what happens. So the definition of worsening heart failure is really important here. These were not patients who are like in the CCU with hypotension or whatnot. These are the patients who were hospitalized within the past 6 months or required outpatient IV diuretics within the past 3 months. So these were the patients that the doctors and the nurses and pharmacists and whoever is involved in the care team thought that they have done all the things that they could possibly do, treated them, and these patients were 2, 3, 4, 5, 6 months post-discharge, right? So this is that worsening concept, or did not even get hospitalized, just required outpatient IV diuretics. The other thing is that this trial enrolled the lowest eGFR of any clinical trial, because again, the problem is the worse the heart failure, the lower the GFR. MRAs are contraindicated GFR less than 30, and the use of RAS inhibitor goes drastically down below a GFR of 45 because we are all concerned. So here we went to the GFR all the way down to 15. So what did we learn in this trial? So here is the primary endpoint. Before we talk about the benefits of the therapy, let's look at the gray line, the placebo line. The annualized 12-month event rate. Remember again, this is not CCU, inotrope, balloon pump. This is 2, 3, 4, 5, 6 months post-discharge or not even hospitalized, just required outpatient IV diuretic. The 1-year event rate is about 35%. 35%. 1 in 3 patients died or got hospitalized. So just gives you a sense that these worsening heart failure episodes are not benign. What is the benefit? So there was a 10% relative risk reduction, which was statistically significant. But many of you may have a gut reaction to say, well, if you look at it, it doesn't really look that impressive, because if you compare with other trials with ARNIs and SGLT2 inhibitor, we have a 20% relative risk reduction, and the curves look more separated than these curves look. So I have 2 points to that. One, remember that the higher the risk, the relative risk reduction translates into a more robust absolute risk reduction, because a 10% of 40% is different than 10% of 4%, right? So the higher the risk. So this 10% relative risk reduction translated into an absolute risk reduction of 4.2%, which was a number needed to treat of only 24. Now, just to put this thing in the context, first of all, this is a completely non-scientific qualitative comparison just to give you an idea. You just simply cannot compare trials against each other without randomization. But just to give you a qualitative sense that, because most of us are sort of in the habit of looking at relative risk reduction and not absolute risk reduction, what is this 4.2% absolute risk reduction looks like as opposed to the other trials we have had with ARNI, SGLT2 inhibitors, and omecamtiv mecarbil. And as you can see, it has ranged anywhere from 2.1% to 5%. So here, the Vericiguat result is right in the line on the upper end of the benefit that we have seen with relatively other trials. There was sort of a similar benefit across all the various secondary outcomes that was looked at, about 10% relative risk reduction. This is the same primary endpoint of cardiovascular death, heart failure hospitalization, divided into heart failure hospitalization and cardiovascular death by itself. Again, you can see that the absolute risk reduction is pretty comparable or better than other therapies that we have seen. Now, another interesting thing is that there was a big interaction with natriuretic peptide levels in this trial. It turns out that it was a pre-specified analysis to look at NT-proBNP quartiles, and the upper 3 quartiles, which, by the way, went all the way up to 5,500 NT-proBNP or 5,300 and something, so still pretty high. But the highest quartile, over 5,300, showed basically no benefit. So if you put everything together, the relative risk reduction was about, as I said, 10%. But if you focus on the lower 3 quartiles, regardless it's a secondary analysis,
then all of a sudden you're seeing cardiovascular mortality and about a 20-25% relative risk reduction, which we have seen in other clinical trials. We then looked at it in a continuous variable fashion, and it turns out that the benefit is seen all the way up to an NT-proBNP of 8,000. So one of the questions that you can ask, well, this doesn't make sense. This is a symposium on worsening heart failure. You're talking about a trial done in worsening heart failure. Well, who has more worsening heart failure than people with high NT-proBNP? And that's the place that you're saying that there is no benefit. But there's one fundamental misunderstanding of natriuretic peptides in the Victoria trial. Remember, in the Victoria trial, these are not NT-proBNP at the time of worsening heart failure event. This is at the time of enrollment, so this is the refractory NT-proBNP 3, 4, 5, 6 months in the outpatient when the patient is home and we have done everything that we can do, and they're still hanging around with an NT-proBNP of 9,000-10,000 patients, 9,000-10,000 NT-proBNP. And my, at least, clinical interpretation is that these are the patients that I showed you that thing about the reason why you want to act in worsening heart failure to avoid advanced heart failure. These people are just too far gone in advanced heart failure, and drug therapy will not work. And this is not something novel to the Victoria trial. You know, Paradigm HF is one of the most powerful drugs, RNA therapy in heart failure, but we forget that when we looked at it in advanced heart failure in the LIFE trial, there was no benefit. So we need to start these therapies early and not wait. And because these lower three quartiles, up to an NT-proBNP of 5,500 or 5,314, because the relative risk reduction was in the 20% range, the absolute risk reduction now calculates out not 4.2, but in the 7 to 8% range in that patient population. Now, the other side of the coin is, I said, well, there are two reasons to find novel therapies. One is that there is residual risk, so we need to improve outcome, but then also is the safety, tolerability, and other drugs are not well tolerated. So Vericiguat sort of stands side by side with SGLT2 inhibitors in terms of tolerability. All of these things about potassium, creatinine, blood pressure, congestion, none of those are issues with this drug. If you look at overall adverse events, if anything, numerically comparable, maybe numerically a little bit lower, no particular difference. Overall, very well tolerated in terms of blood pressure and other things. If you look at blood pressure with respect to age, starting blood pressure, or the use of ARNI or not, really very well tolerated from a blood pressure perspective. Very well tolerated from a GFR perspective. I don't have a slide here, but very well tolerated. No hyperkalemia, no hyponatremia, none of those things. Now, another thing that we have seen, so this is just one observational registry, so we got to take it with a little bit of a sort of a pinch of salt, this one, but is that we have seen with other medical therapies that people who are intolerant to medical therapy for all of these other reasons, once you give them a therapy that stabilizes their heart failure, like mitral clip or like these, cardiac resynchronization therapy, when the heart failure gets stabilized, all of a sudden, you are now able to go up on the medical therapy again. So you kind of get dual benefit, both with the device intervention and then up titration of medical therapy. And this is the first report that is now showing that people who were unable to take therapy and were started on Vericiguat, after initiation of Vericiguat, other medical therapy could be up titrated as well. Now, there's a class 2 recommendation for it. Remember that in order for having a class 1 recommendation for any therapy, you need 2 clinical trials. We only have 1 trial with Vericiguat right now. We are waiting for another trial. I'll show you that data, but it is. So both worsening heart failure as an entity and Vericiguat as a therapy for worsening heart failure are now globally in the guidelines, both in the American and the European guidelines. So now comes the quintessential question. Today, when you see a patient with worsening heart failure, you are not going to find people on maximum doses of all 4 drugs. So what do you do today? Do you go ahead and up titrate all the other medications and wait for the patient to fail again? Or do you go ahead and while you're up titrating the other medication, start Vericiguat at the same time? These are 2 approaches. Let me ask this question to Dr. Green after my presentation. Let's hold off on that thought. But this is sort of a really, really important question, because this sort of fundamentally goes into this thing, what is the baseline therapy? At the end of the day, the baseline medical therapy is really not optimal. There's a lot of opportunities, and how long do we try? And, If somebody is not tolerating, do we wait? And all that kind of stuff that sort of gets into it. Remember, when people develop worsening heart failure, improving their symptoms and getting rid of the congestion is the #1 goal. But the #1 goal is not the only goal. The ultimate goal is to make the biology of the disease better so that they can live longer and feel better and live, in the long term, things get better. Another simple example I give to the medical student, if you have somebody that comes into the hospital with pneumonia, they have fevers, chills, and cough, and you give them high doses of antipyretic and you give them high doses of codeine or some cough syrup, and you round with your team and a bunch of medical students and you say in the morning, how are you feeling better? Yeah. Is your cough better? Yes. Can you change your clothes? Can you shower? Yes. Can you walk to the nursing station? Yes. Okay, you can go home. How many of us will be surprised that this person will come right back to the hospital and will be at a high risk of mortality because you've done nothing to the biology of the disease, which is to give antibiotics? How do we decide who is going to go home after a heart failure episode, right? We give them diuretic. Granted, I'm taking a little bit of liberties. Diuretic is not exactly giving pain medicines, but nevertheless, we diurese them. Their shortness of breath gets better. We have done nothing to the biology of the disease. We have not given them any changes. We ask them, can they walk to the nursing home? Okay, you can go home. And then we are surprised that these patients keep coming back into the hospital. So the other goal is to prevent further episodes as well. So as I said, both the ACC, AHA, and then the ACC expert consensus decision pathway specifically now recommends the use of Vericiguat in patients with worsening heart failure. There are some tips, so you might want to have the Journal of Cardiac Failure paper be noted. There's a lot of sort of good tips in this paper for the use of this drug, and we'll discuss some of these things in the discussion session as well. Now, for the completeness sake, I also want to say that another therapy that has been tried, but to the limited group of patients, is IV iron therapy. So there were trials done in hospitalized patients, but if you're iron deficient, so this is not for everybody, then IV iron replacement also tends to decrease rehospitalization rates in these patients. This is a paper that Dr. Green and I led in JAC. This sort of gives all of this historical background that I have given, but raises this fundamental question that quadruple therapy is the foundational therapy for chronic heart failure. Should it be quintuple therapy for worsening heart failure, which goes back to the question that I asked, which I would ask Dr. Green. So the key takeaways: worsening heart failure is very high risk, it's very frequent, that there is substantial residual risk even after quadruple therapy, and even more so if quadruple therapy is not tolerated or delayed. Early upfront use of Vericiguat in combination with other therapies substantially reduces the risk, and that if preferably be given in the hospital setting, but worsening heart failure does not go away at the time of discharge, even in the outpatient setting, this will be of significant help. Thank you very much. So we will now transition. Oh, this one more slide. I mentioned sort of in the beginning that remember, there's nothing about the molecule that this is only about worsening heart failure, so there is an ongoing trial in the non-worsening heart failure patients. So sort of all the chronic outpatient who are otherwise doing okay, that trial is ongoing. So Dr. Adams will have to just invite me next year, and maybe we'll have some results by then to share. Okay, so thank you very much. So please do write your questions on the cards. We would love to answer your questions, but let's have a short panel discussion. Nancy, do you mind if I start with you? So when somebody has decompensated heart failure and gets hospitalized, that's sort of pretty black and white. But what are some of the signs or buzzwords on history that starts making you worry about that this person is slipping in the outpatient setting?
Yeah, that's a really important question, and I would imagine most of you will have some buzzwords in your head, elevated N-terminal pro-BNP or whatever natriuretic peptide you use, dyspnea, fatigue, edema. And you may even have some unusual ones, elevated jugular venous pressure because you're assessing it, or ascites, or liver hypervolemia. But I want you to also think about things like, have you increased the dose of diuretic in the last few weeks, or even today you're thinking about increasing the dose of diuretic? That is a sign of worsening heart failure. Or maybe you are deciding that it's so bad you need to get out the sub-Q 80 milligram Lasix furosemide packet that we have now for patients. So again, think about the bigger picture. Also, you got to ask patients questions. If you just ask them, are you more short of breath today or are you more fatigued today? They are going to tell you no, possibly because they stopped carrying out the activities that got them into trouble previously. And so you need to really ask poignant, very specific questions. You know, when you walk up the steps to church every Sunday, if you know they do that, can you get up the steps as fast as you used to? So we need to better understand those subtle signs and symptoms that tell us our patients are in trouble. And then when it comes to end-terminal proBNP, we need to remember that a 30% increase is a sign of worsening heart failure. So if their last value was 400, 30% increase is 120, so it's only 520. Somebody may be thinking, no big deal. That is a big deal for that patient. So I think we just need to look at that totality, and don't forget about the diuretics. It's not just IV diuretics. It's not going to the ER. It could even be those small little changes. Maybe they're on PRN diuretics because you were able to take them off of everyday use, and here they're telling you that they've had to use their PRN dose 3 times in the last 2 weeks. That's a problem.
Good. So, you know, the reason we did IV diuretics as part of the clinical trial definition is that having a consistent oral diuretic increase across global trials is difficult, right? I mean, do you say a doubling of the dose or, you know, increase by 50%, or how do you equate going up on the dose of furosemide versus adding a second diuretic? So those are sort of technical reasons. But the number one way by which worsening heart failure is treated, because most of the places don't have outpatient IV diuretic opportunities, so it's actually going up on oral. So there is in US, there is a heart failure collaboratory that worked with the regulatory agencies. In Europe, the European Society of Cardiology, Heart Failure Association. They both have put out documents now equating need for oral diuretic on a sustained basis as worsening heart failure. It does not have to be IV diuretic. So Steve, can I ask you one question? If you have a good resident, they will take a detailed history, and by God, they will come up with some precipitating factor, right? I took an extra slice of pizza. By God, like if you took one pizza, like that's it, it's all your fault. When is it a precipitant, and when is it worsening heart failure?
So it's a great question. You're right. Whenever someone gets admitted, to the hospital overnight, we always got to figure out, well, what's the reason they're here? What's the reason we're here? And the thing I'll just say is that the first thing to look at is not to blame the patient. We need to look in the mirror and honestly look at the last clinic visit. When the patient was in the clinic and they were quote-unquote stable, what gaps in GDMT were there? I mean, what do we expect to happen with a condition that's an extreme risk condition? You don't prescribe therapies proven to prevent hospitalization. Well, guess what? People get hospitalized. And I think we need to own that as a heart failure community, and to not just say, oh, well, you missed 1 dose of your medicine last week. Oh, bad patient, that's why you're in the hospital for a week. Come on. We need to do a better job. And if you do want to just think about that too, if your biology, you say, oh, that patient is so tenuous that he misses 1 dose of medicine that they're going to be in the hospital for a week, first of all, it's probably not true. But also, we need to understand that's an extreme high-risk patient. How tenuous is that? If you even want to go down that line of thinking, which again, I'm not saying we should, but we need to say the overarching precipitant is gaps in GDMT. That's the evidence-based thing. Salt, diet, for every minute we spend talking about that, we should have been better off spending a minute talking about GDMT access and how we're going to make sure the patient's adherent to the best of their ability and actually get prescribed what they need.
I mean, this is such a critical point, right? At the end of the day, the practice of medicine is an art, right? So you'll use sort of your best judgment. So if somebody with heart failure, absolutely nothing was going on, they had a motor vehicle accident, they're in the orthopedic floor and got like 10 liters of normal saline and developed heart failure symptoms or edema or whatever, that's not worsening heart failure, right? We all sort of agree with it. That's like the 10 liters of normal saline. But all of these other things, medication, prescription refill was delayed by 2 days, went to a wedding and had soup and salty food, grandchild came with a runny nose, then I had a runny nose. So there's a huge sort of a denominator bias here, because what we don't keep into account is how many people that we see in the outpatient setting with exactly the same thing who do not develop worsening heart failure. For all of these minor things to happen and for you to flip into worsening heart failure basically tells you that you need to be living in a completely ideal bubble, and anything outside of that, you just fall into that because you have no cardiac reserves left. So again, just sort of put that a little bit into perspective. So Robert, let me come to you. We are talking about a lot of theory here. So let's put it some practical thing. How
All
do
right.
we do it? Tell us about the
So-
hospital setting.
I'm going to say oh, all right. There we go. So, whatever, I guess I'm going to. All right, so to that nature, to answer that question, the first thing is I work as a CICU pharmacist, particularly with the Advanced Heart Failure Group, working with Larry Allen. And one of the things that we did, if you work within a health system that needs to be, I loved the idea, again, that we try to avoid hospitalization, but actually patients, during their stay, they're a captive audience. You can do rapid titration. You can get medications initiated. I can evaluate on day one when they're admitted whether or not their insurance coverage, believe it or not. I mean, that's one of the benefits I offer. Larry goes, I don't know how to find all that. And so I manage our Medicaid benefit in the state. So I know what's on our preferred drug list. I know what Kaiser covers. I know, again, what Denver Health, which is our emergency hospital, our indigent hospital. And again, and in my own institution, I had to fight in order to get Entresto and the SGLT inhibitors on the inpatient formulary. And I had to fight in each case. I had Endocrine who owns these, and they're like, my drugs, no, you're not bringing them in. These are outpatient medications. You're going to make everyone have DKA and blah, 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 blah. Well, we got it on board, which was great. And now, as I said, so when someone in practice, when someone is admitted, the first thing that I do is I check their formulary. That's number one. And then also, we then have the access to initiate in-house. Now, right at this point, for Vericiguat, do you have it on it, Duke, or you guys, yeah? We don't have it on the inpatient side, but I want to get it on the inpatient side so we can get these drugs initiated. The other thing I do want to highlight that is coming down the road, and I want to warn you all, believe it or not, it's been almost over 20 years since Entresto is now going generic. It's been around, so it's going generic in 2025. I want to remind you, you're probably going to think, oh, that's so great, I'll have access, it's generic, it'll be cheap, blah, blah. No. The next 2 years following it, what you're going to find is that the cost of the generic is going to be skyrocketed. And in fact, it's cheaper to use the brand. And sometimes when a drug falls off formulary, I mean, honestly, the one thing, or not a formulary, off brand, one of the things I enjoy is that actually when you work with industry can assist you. We have options, da-da-da-da. When this drug goes generic, and like Vericiguat goes generic, ain't going to have no coupons. You're not going to have any of that. And it's going to, I think we're going to be in a catch-22 that people, I don't know. Now, if they have third-party insurance, not a problem. But unfortunately, as you see, one of the things that I highlight is access. That's what I do as a pharmacist, is access to care and also with regards to affordable medication. And that's what I bring into the table. But I bring all of those issues surrounding what is covered and what is not. The other aspect of that is a lot of people go, I don't want to increase and titrate in the hospital. Well, actually, we can do that quickly. The other thing is I can make sure that they leave with the medications. My last point, take home, to Dr. Green's point and also to Dr. Albert and Sarah Paul, who talked about health literacy and that. Dr. Green, I agree. Would you give just a 10-minute talk to somebody who has cancer on their chemotherapy? That would be a big no. If you really do think of heart failure in that spectrum, chronic disease, high mortality, pharmacotherapy is the cornerstone. And so you would not, so why in the world would we not want to provide education? But unfortunately, my clinician providers, you guys don't have time. I actually do, and I will spend the time. And that, I find, is the biggest impact. That 73% works every time. It's just like a DOAC. It's like, do you want a stroke? No. Okay. Got to put it in perspective. No, I'm being really serious. You've got to be honest, but you've got to put it into their perspective. So, again, sorry to ramble.
Can we record your education session with the patient and distribute to everyone
so
that they can just play it with their
but
patients?
You've got to adjust for health literacy, and that's hard to do on the fly. There are certain key things that I look for. If they can't tell me what a medication's indication is, or they go, well, that atorvastatin's for my kidneys, then that's a whole conversation's completely changes in terms of how I approach it.
Super. So Dr. Green, I'll come to you, but in the meantime, if you guys have questions, there are some that have come up, but otherwise also this is, reasonably informal. If you want to come to the mic or have any questions, please feel free. So coming to the question that I raised at the podium, so today, the overwhelming likelihood is that the person that you're seeing with worsening heart failure in the hospital or whatever is likely going to be on 2 or 3 medications, very unlikely to be on 4 medications. Can you steelman the case for just start the foundational therapy and wait for people to feel worse, or go ahead and while you're doing that, go ahead and Vericiguat at the same time?
Yeah, so it's a great question. So first thing I'll say is, let's put all the issues with cost and access and all that to the side for a minute. Let's just talk a scientific argument. Not saying they're not important. They're critically important, as Robert just highlighted, but let's just put that argument to the side. We should have, in my opinion, better respect for what a diagnosis of worsening heart failure really means. Like Robert just said, it's a cancer diagnosis. Scientifically, if I told you that you had, unfortunately, a diagnosis of cancer, would you say, I just want some of the therapies, I don't need all of them? People in the lay public, they would say, I want every possible tool to help me live longer and stay out of the hospital.
And how fast can I get it?
Yeah. Yep. Exactly. So to me, it seems inherently problematic in my mind to say, well, yeah, you have this extreme, very extreme high risk issue, diagnosis. I'm going to give you the foundational therapies, but I'm just going to hold back on the other therapies and wait for you to fail, and then I'll actually reach for everything. I already know you're extreme high risk. Why would I not want to give this diagnosis every possible tool to try to make this better and prevent bad outcomes? So that's the kind of rationale. I know we had it on the slide as like reasonable approach number 1, reasonable approach number 2. But again, from a scientific argument, not doing quintuple therapy and treating this horrible diagnosis with everything we got just seems problematic to me.
And it's fortunate that your hands are really tied. And I have to remind this to my preventive cardiologist who want everyone to get a PCSK9. And I'm like, I can't just make it out of the air. But PBMs are tying your hands. That's one thing I've run into that with Vericiguat, trying to get it initiated I can get it on an inpatient, but then jumping through some of those hoops, which is nice. You could do that, do PA criteria stuff while they're in the hospital. But again, you're limited. Your hands are tied by PBMs.
I'm going to make a comment here, and I think we can accuse each other or ourselves of this, and that is that we use the word stable when we talk about heart failure way too much. My opinion, and I'm trying to get all of my nurses at Cleveland Clinic to understand, is to take that word out of our vocabulary. If you see a patient and you think they're stable in clinic that day, don't use that word. Say you still have persistent heart failure. I'm glad you're feeling great today, but you've got persistent heart failure, because patients get this idea that their heart failure is stable and they don't need to come in for up titration. They don't need to come in for follow-up. It's okay if I cheat and do this or cheat and do that. And so they get this mindset that their arthritis is worse than their heart failure. Their arthritis isn't going to kill them. Yes, it may make movement difficult, but it's not going to lead to death. So I think we really need to change our nomenclature when we're talking to patients. If we say constantly your heart failure is still persistent, I'm glad you're having a great day, I'm glad everything is going smoothly, but you need to come in because we're worried of a change. It's normal to see progression of this condition. Then that changes the mindset in somebody's mind. They may be more likely to be adherent to their medications. They may be less likely to have a worsening diagnosis. And then when they do, and we want to add a new drug, so now they're on 5 core drugs, plus their diuretic and their aspirin and whatever else they're on, they understand what's going on because they understand all along that their condition is persistent.
So let's sort of think about it quantitatively for a second, right? So I showed you the data that in the Victoria trial, these patients, again, worsening heart failure was not even getting hospitalized, outpatient IV diuretic, or hospitalization within the past 6 months. So these are not ICU sort of patients. And the 1-year event rate was 35%. I also showed you that in the recent clinical trials, the absolute risk reduction with therapy was in the range of 4 to 5%. So suppose if somebody is on 2-drug therapy and you add the other 2 drugs, you will have, say, cumulative benefit of another 10% relative risk reduction. Let's even up it more. Just say that it's not going to be 5, it's going to be 7.5%. If you cut that risk by 50% relative risk reduction, you're going from 35% to 17, 18%. Still 1 in 6 patients is going to die or come into the hospital within the next year. And that, to me, is the biggest reason why it makes a lot of sense to start therapy, combination therapy, as soon as possible. Okay, so there are 3 overlapping questions here, and they're all related to dose titration. So let me start with sort of the simplest one, for which I don't even know how you guys feel about it. So somebody started on Vericiguat, they're on 5 milligram, and they're doing great. Do we need to go to 10 milligrams or just leave them at 5 milligrams?
You want to start, and I'll add.
So we should, again, it goes back to what the healthy respect for heart failure, and the way that was done in the trial was to not just rest on our laurels and keep people at low doses, but is that if they meet criteria and they're stable, I don't want to use that term actually, but
Thank you.
yes, exactly. But we should push the doses. That's for all our GDMTs. The trials, there's no trial of just like, let's say, lisinopril, an old school therapy. Hey, let's just start 5 of lisinopril and just leave it there. No, all the trials had very protocol-driven up titration. That's how you generalize the clinical trial results to practice. You try to push the doses. That's exactly what they did in the Victoria trial as well. So we should try to get to the target dose of 10 milligrams as tolerated.
So I agree completely, and what I would suggest is when you first initiate the drug, I do this for all my drugs that require titration. I tell the patient, this is a drug that's like going up a bunch of steps. We're starting you at the lowest step, and the next time you come in, we'll increase the steps, or I'll call you at home, or I'll figure out how I'm going to get you up titrated on the dose. And I even say I expect to be doing this within 2 weeks, so they're not waiting 3 months and thinking that's okay. Because otherwise, in their mind, they're thinking 6 months from now, something's going to happen. So, and I won't even order a whole year prescription. I'll say to them, I'm just going to order the lowest dose, and when I increase it, you'll take double of that. But then when you get to the top dose, I'll give you a new drug, so you're back to 1 a day, or whatever the regimen is. So again, I think it's really important to have that discussion early on, so patients really understand why we're increasing the dose. This is based on research evidence that we have that we're trying to get you to the right drug and the right dose.
So Steve, there are 3 questions here that are very overlapping with certain different nuances, and they're targeted at you. And that is, you talked yesterday and today about sort of the sequencing and whatnot. So let's just go over it one more time, that barring contraindications, you don't have a GFR of 10 or something like that, barring contraindication, and somebody comes to you and with worsening heart failure, and they are only on ACE inhibitor and nothing else. Just talk to us. How are you going to sequence 5 drugs? How many days? Which one's first? Which one's second? How would you approach?
So the top priority for a patient that's minimal GDMT is to at least sprinkle. I use the word sprinkle. That's what I say in practice too. We're going to sprinkle at least low doses of all the indicated therapies. That's where you get the biggest bang for your buck. Not to say, oh, I'm going to start 1 or 2 up titrated up to medium or high doses, then I'll start the 3rd and the 4th and everything like that. So this patient you're describing like only on ACE inhibitor, we got a lot of work to do, okay? If you're an inpatient, I think we should say, hey, we're going to do this during this hospitalization. They're going to be here for median length of stay 4 or 5 days. At Duke, just like Robert said, day 1, we're starting the price checking. We're starting the access questions right away. So because we know the goal 4 days from now or 5 days from now is they're going home with every possible evidence-based therapy. So inpatient, that index hospitalization, that's where we need to get at least the low doses of all 5 therapies, quintuple therapy, I'm thinking, at time of discharge prescribed. Outpatient, we need to be willing to say, we're going to get nowhere as a field if we're not willing, but we need to be willing to start more than 1 medicine at the same time. We have to. We cannot do this 1 visit at a time, 1 in-person visit. So what I routinely do is I routinely will initiate more than 1 drug at an outpatient visit. And for some patient that is going to need maybe 3 or 4 drugs, what I might do is say, okay, you're going to start these 2 today, but I'm still going to prescribe the other ones. But don't start them right today. Wait a couple days, 2 or 3 days. And make sure, as long as you're feeling okay, then start the drug, okay? I'm really a stickler, a maximum of 1 week. I want to get all at least sprinkle low doses as tolerated. That's the goal. The wrong answer is saying, okay, well, I'm going to start 2 today. I'll see you back in 3 months, and we'll start the other ones there. That's the wrong answer. We can't do that. So we have to at least, whether it's a virtual visit or if the patient has good health literacy, they can start these therapies on their own, and we check back. My nurse will call them in a week or something. But the wrong answer is saying, I'm only going to start some and see you in 3 months. So my long-winded answer there.
Do you also ask them to tell you if they're having side effects and not call somebody else? I can't tell you how many times I have patients who call another provider with dizziness, low blood pressure, and the first thing that happens is stop the drug. And then they call me up, and then I have to say, no, I don't really want you to stop that drug. We're going to restart it, but I'm going to have you take it at a different time, or I may decrease the dose a little bit, depending on what's going on.
Or they Google. I hate Google. Dr. Google, and it says all like, you're going to get a UTI if you take this. And they're like, I'm not going to do that. And you have to be fighting that too.
Yes. I just had a patient who's no longer taking his SGLT because he went online and found out it increased arthritis, and his arthritis got worse. So I tried to explain to him it had nothing to do with his arthritis. He wouldn't listen, so I put him on the other drug, another SGLT. I said, we're going to try the other drug. So again, I'm like, you really need this drug.
That was smart.
Yeah.
Yes.
So I'm waiting to see what happens. I just wrote this order yesterday.
So we're running out of time. A couple of very quick questions. So Robert, Nancy, anybody, let's talk about the opposite patient who doesn't have worsening heart failure. You're seeing the patient. What do you educate the patient? What to look out for? When should they be contacting you at the earliest sign? Like what are some of the things you worry about?
All right, so I'll just mention physical activity. I'm a huge proponent of patients staying active, and it's a really good way to find out what's going on with them, because if they can't carry out the same physical activity they were doing a month ago, whether they're taking naps more often, whether they're just not walking as fast, whether they can't carry the groceries they were carrying before. So you can say to patients, you know, you need to be active. It doesn't matter. You don't have to be an Olympian. You don't have to be a runner. You just need to stay active. And then if you notice changes in your activity, let me know. And that's a really good way of helping patients to not only do better overall, because we know physical activity can be very beneficial to our patients with not just HFrEF, but HFpEF as well. And then we just need to remember that, and we talked a little bit about it yesterday, that we're not, for patients who are persistent but not in acute distress, we're no longer really saying that you need to be on a 2,000 milligram low sodium diet. You could be on a more, a diet that maybe is around 3,500, maybe under 4,000 milligrams of sodium. We don't have an extreme cut point anymore. We want people to eat healthy, so we need to remind patients that food is medicine. We want them to get fresh foods. You know, we have to still tell them to stay away from boxed, canned, etc., but not giving them that strict cut point will give them more minerals, more vitamins naturally, and help their general health and their immune system. So.
I guess from my standpoint, one of the things that we highlighted yesterday, Dr. Albert, was regards that these pills, they're not just pills. They're liquid gold. They're gold. They're life-saving. And I have to say, one of the key things that I do is to translate that. Because, again, you guys may not have that, but is to say, I mean, these will save your life. And the other thing, too, is, sometimes, like with cholesterol or whatever, they stop taking the meds. They're like, I don't need to take that. Da, da, da. And I always inform people, if you stop taking these meds, you are going to feel like dirt. And you don't want to do that. But I also warn them about the beta blocker in about the first 3 months, and that after that, you're going to feel like $1 million. But patient expectations, make sure that they understand it. When are they going to see the benefit? And then, and again, you'll get a return on your investment.
So we have run out of time. There are 2 questions that I won't answer. One is a specific question about cardiac surgery. So please catch any one of us, because the answer depends on what cardiac surgery it is, and it's not a generic answer per se. And there was another SGLT2 inhibitor question, but we have sort of run out of time. So my sort of summary for this session is sort of 3 things that I learned from this session. 1 is that worsening heart failure is bad. 2, that you need to give the therapy fast. And 3, that Dr. Page needs to move from Colorado to Texas and join our practice with that passion that he has.
I don't know. That humidity, Dr. Butler, I don't know how you deal with it.
But I very much appreciate all my colleagues here and their wisdom, and thank you for your engagement. Please don't forget to fill out the forms for credits.